wants to start? Chris wants to.
Actually, I have a question that was raised yesterday in a little bit of a different seminar on healthcare yesterday as part of a different series. And the issue was raised, I think by Mike, about the merger of MGH and the Brigham a few years ago, the Partners Healthcare, which raises the interesting question, can we have cost control while we have essentially an oligopoly in hospitals?
Regina.
I'm tenured, so. No. There's very good data, a lot of economic evidence that oligopolies, mergers in the hospitals typically raise prices and may diminish quality. So, no, I don't see how we can have it.
So Reggie, when that merger was approved by state authorities, I won't tell you who the Secretary of Health and Human Services was at that time, but his initials was CB. Advice to the governor, right? Was that issue ever raised? Andy, you were on the scene at the time too, weren't you, in a different capacity? Were you at the Hospital Association?
Yeah, it was not raised. I was actually attended the press conference when that was announced, and when it was announced, there was a big flurry of how much money would be saved. And it was a year later when the Mass General opened up its own obstetrical unit, which called into that into question.
Having stolen some obstetricians from the Brigham, its erstwhile partner.
Right. However, let me just put one pitch for how disruptive innovations in the market can make a difference. And while I don't disagree that we have a cost problem that's in part driven by market concentration, for 40 years, Harvard Vanguard, where some people have gotten their care in the past, admitted its patients to the Brigham and Women's Hospital. And a year ago, as a consequence of signing this contract with this health plan, the leadership at Harvard Vanguard Atria went to the Brigham and said, we need a better deal because we're being held accountable now for quality performance, by the way, process, patient experience, and outcomes, and for cost. And they're taking their business to the Beth Israel. And I'm not suggesting that's going to solve all the problems in the world, and that's happening around not eastern Massachusetts and western Massachusetts now. So I'm seeing some promising signs, and I think if we can put sufficient pressure on the system, transparency, market forces, the single most expensive piece of medical technology is a physician's pen, because they write all the orders for the drugs and the tests and the procedures. And that's what we have to influence more than any other single thing, and I think we're starting to do that.
And of course, it may involve some patient dissatisfaction. Because the guy that operated on me, can I be indelicate tonight? For hemorrhoids. And by the way, did a pretty good job.
Stop there, Mike.
After this is over, I'll ask Reggie what she would name this guy.
There's a Seinfeld episode about that. There's a license plate.
Apparently, I'm not going to be able to go to him if I have a recurrence. And he's actually very good. Anyway, but here was a case, folks, and even though the guy's initials were CB, he wasn't the only person who was in a nice deal, because we had an attorney general, a good friend of mine, and other people out there who were presumably protecting us, who went along with this. And the reason, Andrew, that these two hospitals merged, and there is absolutely no healthcare reason, whether it's quality, efficiency, or otherwise, for merging a 700-bed hospital and a 1,000-bed hospital, because we've got studies coming out of our ears that tell us that the most efficient hospital is 300 beds,
Little ones.
3, 4, 200,
Little ones.
right? This was all about defending the general, if I may say, at a time when what we used to call the Harvard Community Health Plan decided that they would select the Brigham as their provider because the Brigham came in with lower prices. And without getting into the details of this thing, the general, now threatened by a major loss of revenue, under the aegis of a former dean of the Harvard Business School.
Yes.
And you can name him after the
CB. No.
JM. Put this thing together in the dead of night and then banged it through the existing state regulatory system.
You know, I must say, I think the government's been very derelict here. The FTC has filed 7 antitrust lawsuits. It's lost all 7 of them. The situation in Massachusetts, not anomalous. It's all
Right.
across the
Right.
country.
Right.
And it is horrifying.
Right, but this was a case where the state had the authority to approve or deny, and the thing just went through like a knife through butter. So here we are, and I don't know what Andrew's paying for MRIs at Partners, but
A lot.
it's a lot. And the real cost of an MRI, Andrew, is what, a couple $100?
Yeah.
Think about it. Okay, John Sarby has the microphone, so go ahead, yeah.
In that vein, I'm wondering about what you think about the entry of for-profit hospitals into the medical care system, and in particular, the whole Caritas Christi deal with being taken over by Cerberus Capital. There's nothing about healthcare, and it's just a takeover artist.
Well,
Love to have both of you comment on that.
Cerberus owns Chrysler, so there you go.
That's the truth, you know.
Need I say
Cerberus
more?
owns Chrysler, which, by the way, in the latest quality ratings, according to my New York Times today, is dead last. And they're the ones that are taking over this. So what do you think, Reggie and Andrew? What do you
Well,
think?
what I will say is that the promising side is less about Cerberus and more about Caritas. Is that Caritas's vision for the healthcare system, we'll have to hold them accountable for doing this, is to actually be a low-cost alternative and to preserve these more efficient community hospitals in places like Fall River and Methuen and Dorchester. And if this can allow a different model of care, which is more community-based and less tertiary-based, we actually admit patients to academic medical centers at 3 times the rate of a typical state. And so in that sense, it could hold some promise. And I guess, although we're a not-for-profit and I'm skeptical about investor-owned businesses in healthcare on the one hand, we are looking for some innovation, and I think it's more their community commitment than their corporate status, which may cause the problem.
I think not in this particular trend deal, but all over the U.S., the private equity industry is interested in making investments in healthcare. So why are they interested? Well, one way would be to say, well, I can make it more efficient. I will apply my skills and I'll make it more efficient. And maybe when Bain bought HCA, they bought that skill set. I don't know. I know some of the people involved. I believe it. The other is just plain old economics 101. I'm going to dominate a market share area. I don't need to know a damn thing about how to run a hospital, but because I dominate a market area, I'm going to make money. I think the private equity deals are dominated much more by the latter kind of thinking than by the former kind of thinking. And again, if we had transparency, they couldn't do it. You know, they just, if we knew what their costs and quality and prices were, relative to comparables, they couldn't get away with it.
Another question? Yeah.
Yes, Mr. Dreyfus, you were commenting, on the increased costs every year due to some of the physicians relative to their increased costs and so forth. Now, I know Blue Cross, we know you're a very large organization.
Right.
If they say to you, okay, for example, in Providence, it's $2,100 for an MRI, and you figure it really costs them around $200. If you said to them, look, we're the biggest in this field, and we're not going to pay you $2,100. We're going to pay you, whatever you feel is a reasonable rate.
Right.
I mean, what recourse do they have if you have all this power? Because I know I had a situation myself where there was a procedure was done in which the hospital billed $2,000, and because it was a screw up in my insurance, I called up the hospital and said, well, how much would it take? And they said $1,200. No problem.
Right.
Why can't you just use the force of
Right. Well, first of all,
to do this?
Your last point is great because it's a hidden secret in healthcare is you can bargain with physicians and hospital and healthcare, and you did that successfully. Well, one health plan, I during the break, someone from Tufts Health Plan came up and talked to me, tried that several years ago, and within a week, the Partners Hospital said they would not agree, and all the employers in the Tufts who are Tufts customers said we're going to drop you. So I think today, Blue Cross or Harvard Pilgrim or Tufts could not offer a product in Massachusetts that did not include the Partners Hospitals. In fact, 25% of our payments to physicians in the entire Commonwealth go to the physicians affiliated with Partners Hospitals. Having said that, we have in the past year, and I think in part spurred by the governor's regulatory action, been much more aggressive in our negotiations with hospitals. And I think you'll see in the next year or two, the consequence of that is that our premiums they won't come down, but they'll go up at a much slower rate. And we do have significant market power, but although it's interesting, we talk a lot about partners, but go to Springfield, where there are two hospitals, but one that is more dominant in Springfield than Partners is in Boston, or go to Central Massachusetts, where the University of Massachusetts system owns hospitals from the New Hampshire border down to the Connecticut border. So it's a larger problem, and this is why we have to think about what are the proper roles. I think with better transparency, with payment reform, we could start to force some of these large, less efficient systems to at least become more efficient and more responsive.
But it just underscores Chris's question of the awesome power of these oligopolies. They have, your question is so logical. Why can't a big, powerful buyer bring them to heel? They cannot. The oligopolies have incredible market power in this and in healthcare markets across the United States.
Now, in the early 90s, there was an effort in this state to do something about that when, led by another one of our friends, Dolores Mitchell, who was the executive director of the Group Insurance Commission, which, as Andy said, insures state employees, their families, and retirees. She assembled a collection of employers and created something called the Massachusetts Purchasers Group. And these were the major employers in the state. I think, Andy, at the time they represented maybe 1.5 million covered lives. And they organized themselves, raised a few bucks, hired a few analysts, and then on an annual basis would say to the healthcare community generally, folks, we've done the analysis, we won't pay more than an increase of 2.7%. And for a while it worked.
Right.
At least it seemed to work until Bank Boston became Fleet, and Fleet became Bank of America, Gillette became Procter & Gamble, and pretty soon poor Dolores looked around and
Nobody there?
her purchasing group had disappeared. Which raises the interesting question, folks, and I won't bother with this, as to whether or not, at least as we get underway with both transparency and, I won't say anything, but what we used to call HMOs and capitation. The government doesn't have to step in and reinforce these efforts. Reggie obviously suggests some kind of government agency akin to the SEC, and while Andy's headed toward what he hopes and expects will be a better payment system, system accountability. The insurers by themselves can't do this without somebody else, and it was a kind of quick and maybe crude and inelegant way of doing so, but there isn't any question that the government is moving on this, got the attention of the providers. The question is what happens now.
No question, and I agree that the employer is a kind of missing piece here, and we have tried to resurrect some of that energy in something called the Employer Action Coalition Healthcare, run by one Joe Alviani right now, another former
Former Secretary of
Right.
Economic Affairs.
Right.
Late
And
state administrator.
and it's interesting. There's a big fight going on in Connecticut right now between the Hartford Hospital and the Blue Cross plan in Connecticut, and there's some other ones. And in some cases, in Connecticut, a group of cities and towns wrote a letter to the hospital, essentially saying, "We want you to keep your rates reasonable for us." And I actually circulated that to my staff and said, how can we get the cities and towns in Massachusetts, of which many have Blue Cross coverage and value it greatly, to start to see our perspective? And we actually had a little dispute going that hasn't been publicized in the Boston area between a hospital outside of Massachusetts and one of the a major city outside of Massachusetts is a customer of ours. And so I called the mayor up. It's my second week on the job. I said, "Will you help us?" And he told me over the course of a half-hour conversation that what he really cared about was the jobs at the hospital. And even though he is going to pay the higher premiums, and I could show him how his premium is going to be forced to go up because the hospital, which has dominant market share in this particular city outside of Boston, was raising their rates unreasonably. So we have a long way, it's a journey, a long way to go.
It will, if I make one more throw comment, it will require the full attention and engagement of the next government.
Yes.
In a very direct way, folks. Because you get a sense of just what the forces are here, and whoever occupies that corner office is going to have to get deeply and actively involved in this from the get-go, recognizing that our healthcare community is a very precious asset to us. You don't want to go in there with a wrecking ball, but you do want to go in there in a way that uses, in my judgment, the power of the governor's office to bring people together and say, okay, folks, enough is enough. We all know the system is nuts. Now, how are we going to sit down together?
So I'd like to underscore Andy's terrific data about that we have the world's most expensive healthcare with some national data. The unfunded, the net present value of the, who invited her? The net present value of the unfunded liability of Medicare Part A, that's the hospital part of Medicare, is $37 trillion. That means the federal government would need to have, right here, $37 trillion to honor its commitments to people who paid into Medicare if it's going to pay for their hospitalization. That's not the drugs and it's not the physicians, just the hospitalization. What is $37 trillion? You know, that's an unfathomable number. The GDP of the United States is $12 trillion. So we would have to do nothing else except fund the unfunded liability of Medicare for 3 years as an economy to bring this home. This is a terrible problem, and the economists call it intergenerational equity, which is a sanitized way of saying we're screwing our children, we're screwing our grandchildren. So here you go. Here's a nice gift for you, $37 trillion, the entire liability. It's almost $100 trillion. It's just a stunning problem. We laugh at Greece. We're no better than Greece when it comes to our unfunded social obligations.
And worse in other respects. Another question. Yes.
Mr. Dreyfus, one of the first graphs that you showed us was relating the healthcare costs in the United States and the increase here with healthcare costs in other countries in Europe and Australia. So can we hear a little bit about how these markets are different? Are we trying to reinvent the wheel with some of the ways that keep costs down?
Well,
taking place around the
yeah, it's really interesting, and Reggie has studied this even more extensively than I have. But first of all, there's great diversity in other countries, and so you, for example, have Canada has a public payment system and a private delivery system. The UK has a public payment system and a public delivery system, and in Germany they have a kind of mixed payment system and a private delivery system. What's common in all those countries is first they set a budget. So someone sets a budget for healthcare, and whether it's done at a national level, a provincial level, or a local level. And but they're all struggling with some of the same issues in terms of growth. And the UK is very interesting. They are now experimenting with a kind of payment reform, and I actually participated a couple months ago in a meeting with a lot of the UK health leaders because they're interested in learning about our payment model. So the levels are lower and the growth rate is not as high, but even in different systems, public, private, different mixes, they're still struggling with some of the underlying drivers, which are technology and aging and chronic illness. But there's a lot to learn from these other nations, and they almost all have better outcomes, and do it less expensively, and they can do it in private markets and public markets, which is why I suggest it's not, the role of government is not this kind of singular issue. But Reggie studied this, especially in Switzerland. So.
Yeah, so, you know, there are essentially three kinds, although as Andy has said, there are mixed models about who or what is public and who or what is private. So there are three theories about cost control. One is managed competition, which is you set up HMOs with vertically integrated, accountable care organizations. They compete against each other. And Israel has this system, and the Dutch have this system. The costs there are much lower than ours as a percentage of GDP. So in Israel, they're about 8% of GDP. Excuse me. We're at 17%, so that's quite a difference. And in Holland, it's about, the Netherlands, about 9% of GDP. But in Israel, 44% of the Israelis buy private health insurance. Anybody who can get out of the system, who can afford to get out of the public system, does it. And in both those countries, the rate of increase is faster than our rate of increase. So I wouldn't call that a successful model. Then there are single payer countries, and single payers, again, as Andy said, in Canada you have governmental control but private sector providers. In the UK you have governmental control, public providers, and some private sector providers. Those systems control costs very well, but again, in the UK, 13% of the Brits have private insurance. People who can afford it buy private insurance. So how do they control costs? Well, you all know Pareto's law. Pareto's law is called the 80-20 rule. Pareto, if you talk economics, he had a lot of laws, so, but one of them, the useful one, was the 80-20 rule. So the 80-20 rule says that 80% of anything is explained by 20% of the possible causes. For example, 80% of the beer in the US is drunk by 16% of the beer drinkers. And as a teacher in a graduate school of business, I know every single one of them. So healthcare is 80-20 in any distribution. 20% of the users account for 80% of the cost. They're obviously very sick. So if you run a single payer system, are you going to annoy the 80% who account for 20% of the cost? You would be in a condition known as not elected. Or are you really going to focus on the 20/80? Clearly you're going to focus on the 20/80. So I want to give you some statistics from the US and the UK and the OECD. The age-adjusted breast cancer death rate in the UK is 26 women per 100,000. OECD, similar demographics, 22 per 100,000. US, 20.5 per 100,000. So you might say, well, only 5.5 more women die in the UK who might have been kept alive in the US. You might not say that if you're one of those women, but if you're doing this kind of calculus, you might say that. And in fact, the UK is one of the richest countries in the world. We don't think so because of the teeth, but they're really kidding. They're very attractive people. The UK buys cancer drugs. There's a whole new class of genetic cancer drugs that are hugely expensive, and they prolong life, but not by much. Okay? So the reason for the difference in the UK death rate for breast cancer, and just to cut to the chase, in the US death rate from breast cancer, is we buy those drugs a lot more than the UK does. And there's very good reasoning behind the UK's decision not to do it. These drugs are incredibly expensive. They don't prolong life by much, and you could use that money for something else. Can we have this system in the US? I don't think so. I just don't think that this kind of substitution would be feasible, whether you like it or don't like it. Politically, I don't think it's a viable system in the US. So what I like is the Swiss system. So in the Swiss system, they have, this is the third way of controlling healthcare costs. I call it consumer driven. They have universal coverage. Everybody's covered in Switzerland, but they have to buy their own health insurance. They don't have Medicaid in Switzerland, which I think is a great boon because Medicaid is a demeaning, lousy program. In many states, up to 60% of doctors refuse to see Medicaid patients because they're paid so poorly. In Switzerland, if you're poor, you get a voucher and you buy the same health insurance as everybody else. Switzerland has the highest rate of equality between rich and poor in terms of access to health care of any country in the world, and they have great health statistics. They spend more than the UK because people, they're spending their own money. And the Swiss people decided to spend 11% of GDP rather than 9.8% of GDP. I like this system, and one of the reasons I like this system is I think it's very American. It's consumer-driven kind of system, still achieves universal coverage. And the thing that's amazing about Switzerland is since 2005, their rate of inflation. So that's because you have a consumer-driven system, and he's now going to kill me. So what is the difference in Switzerland? They have 87 private health insurance. They have no public system, no Medicare, no Medicaid. It all goes private. They're ferociously competitive. To give you an idea how competitive they are, some of those health insurance companies are run by nuns up in the Alps. You know those are tightly managed insurance systems. So the average cost of administration...
I'm going to hire a nun as my COO.
We have this program, the Harvard Business School, called the Advanced Management Program. And for years I used to laugh, not funny, that the only woman we'd see in there was a nun who ran hospitals. Anyway, the administrative costs in the United States of health insurers between 12 and 18%, and these costs are unusually low. What do you think they are in Switzerland? High or low? 5%. same rate as Medicare administration. So that's how they do it. They've got a consumer-driven market. You pay out of your own pocket. You know how expensive health insurance is. My health insurance costs $20,000. $20,000. That's what Harvard University pays for my health insurance. It's really my money. So they're taking half my salary and using it for health insurance. I'm just checking. It's late at night, you know, woman's voice, but it's a fortune. So, you know, if you pay out of pocket that fortune, you get some.
Regina, let me ask you a question though. You say they have decided they're going to spend up to 11%. Who controls that?
Nobody. They could spend, so Governor, they could spend, if they bought all HMOs, they have HMOs, they have PPOs, they have all kinds of policies. Let me give you an example of a policy.
But nobody puts a cap on it.
It's their money. If they bought all HMOs, Switzerland would be at 8% of GDP, but they don't want to buy that. Here's a policy I love in Switzerland. How many of you had oatmeal or yogurt for breakfast? How many of you don't smoke or stopped smoking? How many of you go to the gym 3 times a week or more? How many of you don't abuse them? So you do a lot to keep yourself healthy. So here's a policy you can buy in Switzerland's 5-year policy. So you have to be with Andy for 5 years. You're not dating, you know, you're in a relationship with the insurer. Here's the deal. They measure your health in the beginning of the 5 years. They predict how healthy you're going to be 5 years from now. They're Swiss, they're very precise. So if you're that healthy or healthier, you get half your money back. Massachusetts, I would get back $50,000 for staying healthy. Would that motivate me to say yeah, it would seriously motivate me. You can't have this kind of policy in an employer-based market because no employer wants to be married no offense, for 5 years. They want to be able to shop their health insurance and they're worried that if they invest in making somebody healthy in year 1, in year 5, when they're really healthy, they're going to be working for somebody else. Consumer-driven market, you can have this kind of policy, you would buy it, right?
I will say, however, a couple of thoughts, and you're right, actually, we're prohibited by state law, which I think is something that should be changed, to have longer than a year-long contracts with employers. But if you take a look at EMC in Massachusetts has really invested in these kind of prevention and wellness programs that Reggie described, and their rate of increase, the 10 to 12% on average in Massachusetts has been the 3 to 4% range. And they're very aggressive about managing and supporting their employees in wellness and prevention, and especially for people with chronic illness. And it is true, 5% of our members constitute 50% of our spending, and 1% constitute on the supporter of our spending. That's a variation on the 80-20 rule. And most of those people aren't traumas or neonatal or transplants. They're mostly people with multiple chronic illness. So that's where we have to target our intervention. It's not just on the healthy, gym goers, but it's the people with heart failure and asthma and diabetes.
Who's got the microphone? Yeah.
Could we talk a little bit about community health care? And what I mean by that, in my definition, I've always felt that we need clinics in every community. We need to stop having us all go to see doctors when we don't need one. Seeing a nurse practitioner. You know, there's just so many services that we don't need to go very far. And would you comment on something like the CVS stuff?
Yeah, I agree with you. I had 2 children, both with chronic ear infections, and they were in a pediatric practice, and I'd say 80% of their 100 visits over the course of the childhood were nurse practitioners. I was never disappointed once, never once did I want. And we actually have to change the whole model of care. And it's partly, we talk a lot about this primary care shortage as a primary care shortage. It's because of the way primary care is practiced right now. One of the things we're working with these groups that we're experimenting with is talking to the primary care physicians that are practicing at the top of their license, meaning just reserving for physicians the care that only physicians can provide. And it turns out it's that's back to the 80-20 rule. And so we need more self-care, more physician extenders, whether they be PAs or nurse practitioners or others, and we need to do it in different settings. In the Dutch system, or maybe it's in the Belgian system, if you make a call at night because you're worried you have to go to the emergency room, someone comes to your home and they come, nurse practitioners and PAs and physicians in little cars, they almost look like little police cars with laptops. And most of the time they tell people, this is okay and you can just, go see your physician tomorrow or the next day or in a week. And so there's unnecessary emergency room visits, unnecessary hospitalizations, unnecessary readmissions because we have a fragmented system, are a big target of where we could conserve healthcare spending.
Reggie, you comments?
Yeah, I think Walgreens back to the 80-20. So what is the problem with chronic diseases? One of the problems is they're very hard for the patient to manage. Their care regimens are daunting, and they're quotidian. You have to do to prick yourself with a needle 8 times a day. It's very hard. So and the system of care is not a system. It's highly fragmented. So this poor sick patient has to deal with many different providers and have really demanding self-care regimens. So Walgreens out of Massachusetts is offering support in diabetes care out of the little centers that are in the Walgreens drugstores. I expect that these retail or community-based centers would be fantastic places for the nurse practitioners who staff them to help people take care of themselves, which would go such a long way to reducing the costs of chronic care, not by saying no, but by helping people to keep themselves healthier.
And in the new national health care bill, the amount of money devoted to community health centers will double. And the number of patients will rise from 20 million to 40 million. And by the way, interestingly enough, when it comes to community health centers, Republicans seem to like them just as much as Democrats. George Bush was a big fan of community health centers. Orrin Hatch was a big fan of community health centers. And so that additional 11 or 12 billion dollars, it is hoped will provide care in that kind of a setting where, for example, PAs and nurse practitioners and others can care for you. And in many, many cases, they do a terrific job. That may end up being the best public option, in point of fact. And it'll be interesting to see just how some of that money is already flowing in Massachusetts, and a number of our community health centers are already.
Whittier Street right up those new facility right up the street.
So that part of the healthcare bill, I think, has strong public support and amazingly bipartisan support. Who's next?
I just have a quick question about transparency. Well, with the advent of social media and everybody is rating everybody else, is that going to have an effect on the need for transparency in healthcare because doctors are beginning to be rated?
Yeah, I think I'm researching that now. Social media clearly is going to have massive impact on healthcare. Where it's going, people keep yapping about Twitter and Facebook and blah, blah. It's honestly unclear to me where it's going, but there are some really wonderful developments. For example, there's a site called Patients Like Me, and it's a site where people who have similar diseases can talk with each other. And one of these sites actually did a drug trial itself. They thought that a certain drug would, I believe the people had ALS, they had Lou Gehrig's disease, a dreadful disease, and there were a number of them who thought that a certain drug would help them, and they convinced the medical community, this group, to let them do a drug trial. themselves within the group. Personally, I love that. I think it's wonderful. The trial failed, but that's not the relevant. The relevant fact is that these people with hopeless diseases got together, empowered themselves, and did something active to try to deal with this disease.
It's 8 o'clock, and we promised you we'd wrap up at this point, so last word from Professor Bluestone.
I wish we had more time for this, maybe another 4 or 6 hours. But let me ask one question, and I know it takes a much longer answer, but I'd like to hear from both of you. Let's say we want to go from 17% of GDP on healthcare to the Swiss model of 11%. We're going to have to cut about 6% of GDP, 6% of about $13 trillion. That's going to mean some people are not going to, some people are going to get hurt. Question is, do you accomplish that by cutting pay, physicians and others, cutting staff? Where is the savings? Where do you envision the savings in the system when you're talking about such large reductions?
So I think we have two sources of inefficiency. So one source is our insurance system is inefficient. We have needlessly high administrative costs, which I just illustrated with the Swiss analogy, where there are more insurers, but they actually, and the Swiss have the highest rate of satisfaction of any developed country, but they have much lower administrative costs. The second is, I think the oligopsony in the healthcare system is a very serious issue, that it raises costs tremendously and may diminish quality due to lack of competition, and we've got to solve that problem, both in terms of lowering the administrative costs of insurers and getting rid of these massive 800-pound gorillas all over the United States that exercise their market power to the detriment of the public.
I'll give you a slightly different answer, which is I sat with one of the top leading primary care physicians at a practice at a large academic center in Boston. I asked him, honestly, tell me what percentage of the care that you provide, your group provides your patients is unnecessary. He said it's at least 25% and maybe as high as 35%. There have been now studies after studies, and Don Berwick, who's now the head of CMS, has led some of these, which have shown that a lot of the care that gets provided in our system is either ineffective or actually harmful. We so much associate in this country that more care is better care. And in fact, better care is better care, and sometimes it's more, but often it may be less. And that I think squeezing administrative costs out of the system would be helpful, although I think the underlying trend would return once some of those savings would be one-time savings. We need savings year after year. So unless I think we have a coordinated delivery system that honestly looks at the effectiveness of care, then we're not going to, and that's really the great opportunity in care. And the magic, or the holy grail, is if we can actually have higher quality care that's less expensive and actually have high value care, then we could have the kind of satisfaction we have in the Swiss or the Dutch system at a lot less money.
I know I speak for everybody here in saying that this has been a wonderful, and if I might add, a delightful evening. I said to Reggie, she hasn't lost a thing off her fastball. And I'm so proud of Andy and what he's done and what I expect he will be doing as he brings his special brand of leadership to this. So our thanks to both of you.